Good. Well, I think we have a quorum now, and it's nice to see everyone. Welcome back to our Wednesday evening webinars. We've had a bit of a break, and my goodness, what a change there has been in the last couple of weeks. And we can get back now, I think, to engaging socially, which we'll almost need a webinar on how to re-engage socially. We've probably forgotten how to do it, but I have to say, going out to dinner with friends and not having the restrictions and the concerns that we've had over essentially the last 2 years was wonderful. I hope it's not a false dawn. I don't think it is. For once, I'm optimistic about how things will pan out. This evening, it's great that we are going to hear from our trainees because you are the most important people in the college, because the college depends on you, and those of us who are a little further on in life will depend on you even more in coming years. So we look forward to hearing your perspective and some thoughts on the new surgical curriculum. The feedback I've had through the joint surgical colleges is generally favourable, but I've no doubt there will have been some teething problems, and your views are very important and will help develop the curriculum over the next couple of years. My thanks particularly to Kevin Barry, who's the National Director of Surgical Education, and a role that he has taken on in the past 6 months with real gusto and energy and enthusiasm. So thank you very much, Kevin. The rules of engagement are, if you're not speaking, kindly turn off your video. And please do mute unless you're speaking. There will be time at the end for a discussion, and so kindly send in your questions on the chat function. And lest I forget later on, we are delighted that the Millen meeting is going ahead on Friday of next week, the 4th. And it will be both a face-to-face meeting in the college, and we have two very important lectures. Of course, the Millen lecture, but also the Carmichael lecture, which will be given by the Deputy Secretary General of the UN, who was in charge of the Sustainable Development Committee, and she, Admina Mohammed, is coming to Ireland specifically to give that lecture. So if it's at all possible, it would be nice to see as many people as we can joining us in the Desmond Auditorium for the Millen meeting on Friday the 4th. So I think I've said enough and hand over now to Kevin Barry, and thank you, Kevin.
Thank you, Professor O'Connell. So good evening, everybody. I'm delighted to facilitate our discussion this evening. I will begin by asking each of our trainees who are participating in this evening's webinar to introduce themselves. So I might begin by asking Mr. Osman Haroon just to maybe within about a minute or so, just to tell us what stage you're at in your training and where you're working at the present time.
Hi, good evening, everyone. Yeah, so my name is Osman Haroon. I'm a urology trainee, ST8, so in my final year. And for my final year, I'm doing out-of-program training in Guy's Hospital in London.
Okay.
And doing a fellowship in adult and pediatric renal transplantation, as well as robotic urology.
Thank you very much, Osman. And then I might move on to Amy Lee Fowler. Amy, can you just give us a summary of what you're at the moment?
Good evening. I'm a vascular trainee. I'm currently doing a year out of programme, performing an MD in University Hospital Limerick. In July, I finished up in ST5, and I'm also on Asset Executive Council as well.
Thank you, Amy. So I'll ask Stephen O'Brien, would you like to introduce yourself?
Hi, my name is Stephen. I'm Stephen O'Brien. I'm a second year surgical trainee working in the Mercy at the moment. and I'm the CSD rep on the ISTG.
Thank you very much. And then finally, Nicola Raftery, would you like to introduce yourself?
Hi guys, I'm Nicola. I'm an ST2. I'm currently working in University.
Okay, so thank you very much. Just to begin then this evening, what I'm going to do is to facilitate a discussion, and I'm going to ask a series of questions, and I guess some of the questions I'll ask may be more appropriate to the more senior trainees, and I'll direct it towards the more senior trainees if appropriate. And some of the questions I'll ask all of you for your individual answers. And again, I'm delighted that we have this forum because I think it's very important that we put the trainees centre stage in all of this. I'm terribly conscious of the training environment that we're working in at the moment. And just as we came on this evening, I could see, to reiterate Professor O'Connell's words there, we now see a significant improvement with regards to hospitalisation, with regards to COVID. So this evening, 739 people in hospital with COVID, of whom 74 are in the intensive care unit. So having said that, I might just begin then by asking each of you how you've found the last 18 months in terms of your personal welfare and how you've coped with the stresses of training over the past 18 months. So maybe starting with Haroon.
Yeah, good question. Thank you, Prof. I think it's been difficult for everyone. For me personally, I was a senior trainee, and I suppose it gave me the opportunity to step up and take on more responsibility as we had illnesses and we had depleted staff at the start of it. So a lot of responsibility from that point of view. And then as we're trying to shift back into the normal swing of things, I think just adapting to what the new norm is, and you know, all the little things that are in your checklist that weren't there before, you need to get all sorted before a patient comes in. So there are things we need to get used to, and I suppose it will be the new norm from now on as well. So.
And then maybe if I can move on to Amy, I guess, Amy, you're doing research at the moment, but before you went into the lab, what was your experience of, we'll say, the day-to-day stresses of being a trainee?
Yeah, I think this had a profound effect on my training. So I was halfway through ST4 when COVID hit. So at a really critical stage of my training, my surgical skills were increasing exponentially, but I don't think we're really cemented at that point. And then during this time as well, I also fell pregnant, which meant that I couldn't have a patient-facing role anymore, and missed kind of 3 or 4 months of clinical placements. So it's had a particularly profound effect on my training, and I don't think at any point, even at points where we had recovered somewhat from COVID and we're getting back to theatre time, it was never really enough to kind of really improve my training experience. So I do have concerns and worries about how, when I do go back into practice, how that will affect me. But I know, you know, I've an incredibly supportive TPD, and the college are very supportive, and I'm hoping that that will mitigate some of the effects that COVID's had on my training experience.
And can I ask you, Stephen, how you found the last 18 months?
It's been pretty challenging. I moved back from abroad, and you know, kind of COVID had kind of really just kind of started kicking off when I started core surgical training. There were definitely, you know, highs and lows in terms of, you know, operative cases, and that made it quite challenging. And you know, again, I echo Amy's point. You know, at a time when, you know, you're just learning surgical skills, never mind having them kind of cemented. So there was a bit of a stop and go kind of phenomenon with that, but you know, it has steadily picked up over the past number of months.
And then Nicola, just a comment from yourself as well in terms of how you found the last 18 months.
Yeah, so similar to Stephen, I suppose COVID has been with us for the entirety of our surgical training so far. So I suppose we're both very excited to start coming out the other side of it now. I suppose it's been impacting our access to the college, access to, you know, research days that would have been part of the normal surgical training environment. So that's been a big loss, I suppose, over the last 18 months, and looking forward to getting those back.
Yeah. And maybe getting back to you, Amy, do you think that there are any additional things that maybe as a college that we could be doing to support trainees in terms of their welfare during periods of stress or periods of concern from a trainee perspective? Would you have any suggestions as to anything that we could be doing better to support our trainees?
I think in general, I think training has to be very much individualized. And I think the new curriculum kind of allows a lot for that. But I think regular conversations with trainers and ensuring that, you know, an individual trainees are met kind of from a professional point of view, but also from a personal point of view. As I mentioned, I've had incredibly supportive trainers during this time, and that has kind of mitigated some of the difficulties that I've faced. And it, you know, it's very much being taken into consideration in terms of my future career development. But I think more improved flexibility in training is the number one thing that we can do for trainees at this point. I think COVID has highlighted the amount of burnout in surgical trainees. It's highlighted the burden of service provision and how that can impact training. And so I think flexibility is really key, and in ensuring that trainees still have their kind of social supports as well as kind of professional supports, really.
Okay, thank you very much. And again, you introduced a topic there, which is the issue of the training and service conflict. I'm going to ask each of you how we can address this. In other words, you've got training commitments and you've got service commitments, and you know, you're trying to fulfill your training requirements on a day-to-day basis, and you've got significant service requirements as well. How can we assist you in dealing with the issue of training and service conflict in your workplace? Maybe if I ask Nicola initially, how do you think, Nicola, we could overcome some of this training and service conflict?
Yeah, Prof, I just think, you know, from a top-down approach, you know, the consultant trainers, hospitals, with support from the college, you know, hopefully should be there for their trainees and realise what stage they're at and what kind of targets they should be hitting for each year of training. I think that's ultimately what it's going to take, and just setting targets at the start of a rotation and hopefully meeting them and checking in regularly. And at the 6 months block, you know, those CAPA sessions as well are all part of it as well. From the service standpoint, it's very difficult. You know, I think more NCHDs is a way around it, but then you're diluting the training for yourself. You know, perhaps the use of AMPs and PA programs could be an answer down the line, but it's not an easy fix overnight, you know.
And indeed, some of these issues will be covered at the Millen meeting on both the Friday and on the Saturday sessions next week, as our president alluded to earlier on. Haroon, from your perspective, have you faced training and service conflict during your training? Have you felt that there have been times where you've you know, missed out on some training opportunities because of the service demands of your job?
Yes and no. I would say, having recently sat the FRCS and everything that involves, I'm sure that goes for all trainees. Like a lot of the exam, especially the clinical side of it, is trying to figure out how you are a day one consultant, and you know, you can see it as a training opportunity as well. You know, in the end of the day, you're going to be a consultant. You need to make decisions. You need to manage your time best. You need to provide for your patients for first and foremost, and the best way to do that, and delegate authority in the best way you think needs to be done.
Yeah,
definitely agree with everything that Nicola said, and she's made some very valid points. You can look at it as a negative, but I would look at it as a positive. You know, it's something we'd all have to deal with through every aspect of our lives. So service provision is always going to be there, especially when you're a consultant. Just looking at the NHS here in London, they have a lot of managers and they deal with a lot of waiting list issues and clinics and booking patients into those operating lists and making sure operating lists are not wasted. So yeah, that's something we could look at and train qualified people to run these theatres and, you know, our departments efficiently. Like the manager we have here in Guy's for the urology and transplant department, you know, he's an LSE graduate with a master's and an MBA, so he's very highly qualified, and runs a good ship, I must say, and make sure it's efficient. And then it's all about teamwork as well. Like, so
it is, yeah, it is. And you've mentioned two things there that I'd like to focus in on with the group. You mentioned the concept of the day one consultant. Moving along in our discussions towards the new curriculum, you've mentioned the day one consultant, and then you've also mentioned the term teamwork. And I think we'd all agree that teamwork is very much at the epicenter of surgical practice. And maybe the nature of the surgical team is going to change over the next couple of years with greater incorporation of other healthcare professionals who can assist us in our day-to-day tasks. So maybe Stephen, can I ask you, what excites you about the future of surgery? I say you've come through a very difficult training period as a result of the COVID-19 pandemic, and yet you maintain your enthusiasm for surgery. What excites you about the future of surgery?
I think, like, despite all that's going on, there are an awful lot of positive things to take out. There's been massive advances in technology. There's lots of devices and lots of new innovation that's happening in surgery. So I think just, it is an exciting time where technology will start being incorporated into surgery. So, for whatever small advances that it will be able to make, I think it is quite exciting. And I think at the end of the day, look, it is a very rewarding career to pursue. So when you add in, this new innovation and, hopefully the increase in hospital capacity and, ability to perform your job, I think it is an exciting time.
Say, Amy, from your perspective, what would you say excites you about the future of surgery?
Yeah, I'd echo a lot of what Stephen has said. I mean, challenges create new learning opportunities, and I think the last 18 months have, taught us that maybe in some ways we have to do things slightly differently. We've adapted a lot in terms of innovation, and it will be good to see that in kind of daily surgical practice. And we've also adapted a lot in terms of our working practices and how we do things. And as I said before, in terms of flexibility in training and recognizing that people do need, their personal commitments honoured as much as their professional commitments. And I think that understanding is going to be very important going forward, and hopefully will mitigate some of the kind of burnout that we are experiencing as a profession. But I think that there's an awful lot of hope on the horizon. And as Stephen said, a lot of new technology that we can harness that can really improve things for our patients and for us as clinicians. And
Nicola, from your perspective, what excites you about the future of surgical practice?
Yeah, definitely, like the technological side of things is definitely very exciting, Prof. The uses of AI, robotics becoming more and more integrated into daily practice is very, very exciting. And so I'm sure Haroon definitely agrees with that. It's all very exciting. I would also echo some of Amy's points there, just with more flexibility in terms of people coming through, and certainly the increase in women coming through surgical training is exciting to see, and performing at the highest level as well. It's brilliant to see, and for the likes of me, just kind of starting out, and seeing women, win things like the Progress Women Fellowship. It's very exciting to see.
Yeah, and again, I agree. I mean, this year, for example, 46% of applications for core surgical training have come from female applicants, and approximately 40% of our SPRs, specialist registrars, across the board are female. So certainly there's a greater representation, and probably we're moving towards a sort of a 50-50 scenario, I would believe, over the next couple of years. Haroon, you're working in a specialty that's very, very driven by technology, and if I could introduce the term robotics and robotic surgery, what would be your thoughts on robotic surgery and how we might incorporate it into our surgical training programs?
Yeah, very exciting times. Urology definitely are leaders in that, and I think it's here to stay. And we do need to, you're right, we do need to incorporate it into our daily lives. I've learned a lot of things from doing robotics and then bringing it back to my other surgical skills. Right now, I'm in Belgium and Ghent doing a week-long intensive course on robotic surgery, and we're working on porcine and cadaveric and canine anesthetized models and doing your logical procedures on them. But it's not just you go in and you do the thing. They've brought in this concept of precision-based learning and progression-based learning, and you can't just step in and say, "Let me on the robot." It's all about meeting certain criteria, and after you meet those criteria, being proficient in those criteria, and after you've been proficient in those criteria, getting into the wet lab, and only after being successful in the wet lab do you go into our patients, and that's something I've learned, which is really important. Proficiency and going through that whole program is the big thing I'm taking away from it this year. Especially, you can't just go on it, but it actually teaches you a lot of how to learn these new skills and how to incorporate it into daily life. And actually, one of the guys who's leading it here is an Irish guy. His name is Professor Tony Gallagher. He's from the University of Ulster. He does a lot of he does a lot of things on proficiency-based progression. So it's called proficiency-based progression, and he's doing a lot of research into it and modularizing every procedure in urology for the moment, anyway, and going forward other specialties as well. And his whole concept is it shouldn't be like the a simulation where you do a simulation, but does that translate into your real life opportunity or activities? It doesn't. Where he has shown this proficiency-based progression, so you get proficient at it, but then you need to progress at it, and only after you progress at each step do you become proficient and safe in the operating room. So that's something that is exciting. I think a lot of our training will turn that way, and we'll have to take it all on. And then robotics-wise, everything can be done robotically. It's a game changer. The biggest procedures in the world, which we thought, no, it's too dangerous to do it robotically, especially here in guys. I questioned them all here. Why are you doing radical cystectomies with ideal conduits? That's an open operation robotically. And, one of the professors here, Professor Shamim Khan, he said, look, you may be able to do it better openly, but the future generation of surgeons are all going to be minimally invasive trained. So you need to develop ways for them to do it as well. And then as time has gone on and they've run randomized control trials into it, they've shown that it gives just as good.
And we will talk about this a little bit later on. One of the directions that RCSI will be moving in the near future is facilitating robotic surgical training on the RCSI campus here in Dublin. And we'll be looking for people like yourself and others to help with regards to having a faculty of robotic trainers, if you like. So we'll be very keen to avail of your expertise in the future as a trainer when we integrate this into our training program. So moving on to the new curriculum and the implications of the new curriculum. Haroon earlier on mentioned the word or the term, I should say, day one consultant. And this is very much at the center of what we regard as the end product of training, if I could phrase it like that. So the new curriculum became operational here in Ireland in July of 2021 and in the UK in August of 2021. Will we need, to incorporate more educational sessions for people in terms of understanding the new curriculum? To date, there have been lots of YouTube videos, and we've had lots of supports, educational supports on various websites and various means by which we're trying to educate the consultant trainers and also the trainees. But I'm conscious of the fact that we're in a transition period, both here and in the UK. So effectively, we've introduced a new curriculum. And now we're saying to ourselves, well, this is the curriculum that the vast majority of trainees have to switch over to, with the exception of the final year trainees. So the new curriculum places an emphasis on competency and outcomes-based learning. So these may be new terms within the surgical lexicon, but I would like to ask each of you as we go through this discussion for your initial thoughts on how you're adapting to the new curriculum. And this is perhaps more applicable maybe to Amy and to Haroon, because I'm conscious of the fact that Nicola and Stephen are at ST2, although I will come back to you in a moment. But maybe if I start with Amy, and particularly Amy, you're the asset rep for Ireland as well. So you sit on a number of high-level committees and you represent the Irish Surgical Training Group in your interactions with the JCST and the SAC. What are your thoughts so far on the introduction of the new curriculum? How have you found it? I know I accept that you're in the lab, but you're involved in the training committees.
I think for the most part, the new curriculum has been very well received, and this shift from kind of arbitrary kind of numbers of work-based assessments to, as you say, outcome-based assessments is very much welcomed by ASSET and by trainees. I think it will be very positive in terms of focusing the trainees and the trainers on what each individual trainee needs to achieve, and I think that's very important. But I do think there are still some issues with it. I mean, anecdotally, there are some trainees who've still maybe found difficulties with engagement of trainers in terms of filling out the assessments. And I know that was a huge problem with the way that the previous curriculum and ISCP assessments were set up. So if the issue isn't time, I don't really know how we'll get around that other than encouraging trainers to become engaged. I suppose when things are new, it's going to be very difficult for people because they're, trying to learn a whole new system and get your head around it can sometimes be a bit overwhelming. But I think there's a lot of positives to take from it. And I think overall it will be a much more positive experience for trainees and trainers. I think, again, it's just about trying to encourage engagement. And again, there will be some difficulties in terms of getting all the consultants to sit down and complete an assessment together. But maybe this might shift things from, these things being kind of an added, tick box exercise to being a mandatory and necessary process, and I hope that shift will happen. But certainly from training committee meetings and from reports of trainees that I've heard so far, for the most part, it has been fairly well received.
Yeah, well, I'm interested to hear those comments. And so, in general, you would have a positive, if you like, opinion on these changes and how they've occurred so far.
Absolutely. I think there will be issues with it. And I think once, the college is open to kind of working through some of those teething issues and hearing trainees' views on what the issues are, I think that's the main thing. And I do think before the onus was very much, I think, on the trainee to try and get a number of assessments completed, whereas I think the new curriculum and the way the new MCR is set up, it kind of shares that responsibility a little bit more, and it makes it a more collaborative approach. You mentioned earlier on about teamwork, and I think surgical training really is kind of teamwork between trainees and their trainers. So I think hopefully this process will kind of shift things in that direction.
Yeah, and again, you mentioned the multiple consultant report, and I get the impression from talking with my consultant colleagues that it's probably more challenging for our consultant trainers rather than our trainees at the moment in terms of adjusting to the requirements of the multiple consultant report. So again, if anybody wants to pose any questions, maybe towards the end, maybe to insert those on the chat function as we go through this webinar, because there may be questions from both trainers and trainees as we delve into some of the issues around the new curriculum and maybe as we explore them in a little bit more detail. So Amy, your impression initially is that you would regard this as a favourable type of introduction from a trainee perspective.
Absolutely. I suppose we're still in the early stages of it, but from what I can tell so far, and certainly talking to my other the other ASSET reps here in Ireland, they haven't heard of any major issues with it so far.
Arun, could I ask you used the term earlier on, the day one consultant. What is your understanding of the day one consultant? In your mind, what do you believe that person represents?
Thank you for the question. So in the recent past, as I've matured, I've learned that phrase changes. Actually, determined the meaning of it changes. As a junior, you think day one consultant, you're looking at you, Professor Barry, he's doing everything. That's not true. I think the day one consultant needs to be able to provide day one consultant care to a patient, make good clinical decisions, But your operative skills can develop as you become after you become a day one consultant, and that's the biggest change in mindset I've had. I will keep learning as I become a consultant, and I will keep getting better. I just need to be at a position where I can provide the skills that I have learned at a good level, but I know that I will get better and better as time goes on. And that's something that in my head I used to struggle with a lot in my training, because I was like, why am I not good enough? Why am I not good enough? But I think as you go through your training, you realize and you learn from your other seniors who are also learning new procedures as consultants, especially say robotic surgery, where people are adapting to it. So the meaning of a day one consultant for me has definitely changed over time.
And what are your plans after you've finished your fellowship, your urology fellowship?
Hopefully, yeah, back to Beaumont, kidney transplantation and urology. That was where I've specialized in, and we do a lot of it in guys. We do, the largest pediatric transplantation in Europe, second only in the world to sick kids in Toronto. We do lots of complex robotic procedures here as well, and lots of complex transplant procedures. So from a transplant and urology point of view, I do feel very confident, and I'm very excited and learning all the time and becoming better and better.
And I think from a training perspective as well, sorry to interrupt you, but from a training perspective, I think you will have a lot to offer as well to RCSI in terms of helping us to introduce robotic training.
Absolutely, and exciting. It's very teachable, it's very
campus.
trainable, and that's the exciting thing. Like, trainees can get involved. If you're a junior, you help assist, and you're an active assistant. If you're a senior, everything is modularized, and you don't progress to the next step until you have figured out that step. And what your learning curve for that is, we can figure out. And it can be a safe manner as well. So very exciting.
The day one consultant is a term that's used by the Intercollegiate Exams Office as well, and I've been an examiner for many years. And now under the new curriculum, we talk about capabilities in practice. Capabilities in practice, of which there are 5. And just to remind you all, what are the capabilities in practice? We talk about, conducting a ward round, taking responsibility for doing a daily ward round. Managing the outpatient clinic is the second CIP. The third one is managing undifferentiated call, and I'll come back to that in a moment. The fourth one is managing the operating theatre list, and the fifth one is participating as a member of the multidisciplinary team, reflecting, if you like, day-to-day sort of consultant practice that we're all familiar with. So the concept of managing undifferentiated call, that can be something that can be quite challenging for trainees in terms of their exposure to emergency surgery. The new curriculum places a very significant emphasis on exposure to the generality of your specialty, but also a very significant emphasis on competency in emergency surgery. And in recent years, that focus on outcomes for emergency surgery has been the subject of a lot of publicity, particularly in the UK, but also to a significant extent here in Ireland as well. So maybe from the point of view of competency in emergency surgery, Nicola, how can we achieve that within training programs? What are your thoughts on the achievement of competency in emergency surgery, leaving aside your specialty interest?
Yeah, well, that's exactly, Prof. I think as trainees coming up, I think sometimes we have to put aside our speciality interest and take on what is a general take when it comes in the door, and you have to, even if it's not maybe what you're specifically interested in, if you're interested in upper GI and you're dealing with, something colorectal when it comes in on take, you have to approach it with the same vigor and the same, want to learn how to manage it, because as you say, a day one consultant in general surgery needs to be able to deal with an undifferentiated take, and that's what our goal is throughout training. It's, I think, COVID, while it's kind of challenged our list, thankfully our emergency list, certainly in the hospitals I've worked in, have been left alone. So I think our exposure, certainly my exposure to general take, be it laparotomies, appendixes that come through the door, perianal issues, I think I've had very good exposure to it. So I'm not sure what we could improve with it. I think just having an open mind as we go through our training and not to kind of corner ourselves off into one specialty too early on.
And in the new curriculum, we talk about phase 1, which is core surgical training, CST1 and CST2, and then phase 2 is now a block of 4 years, extending from ST3 to ST6. And under the terms of the new curriculum, the majority of the emphasis on specialisation is in ST7 and ST8, which is labelled as phase 3. So phase 2, which is the middle ground, which is that block of 4 years, is very much the phase in consultation with your training programme directors for your various specialties, where you're expected to have a wide exposure to the generality of your specialty, including significant exposure to the emergency surgery component of your specialty. So how do you all feel about this maybe move towards a greater emphasis on the generality of your specialty and emergency surgery? Sometimes trainees are very anxious to move into specialist jobs, maybe as early as ST5 and ST6, and may believe that, say, the early years ST3 and ST4 are there for sort of some exposure to general and emergency surgery, and that when you've 3 and 4 passed through, that you go on then into sort of specialisation. We have been accused in the past of producing surgeons that are maybe too specialised and less generalised in their focus, and perhaps maybe less confident about the management of emergencies. So Amy, what would be your feeling about, say, the emphasis on the generality of each specialty and exposure to emergency surgery?
I think in general, I think that it's important to retain specialisation of trainees, and that would definitely be ASIT's position. However, I do think that trainees do need a very good foundation in terms of general skills and emergency surgery. I think that can only improve confidence. So I think ensuring that trainees have a very good foundation before they go on to specialise is very important. But I think retaining specialisation is also crucial for surgical trainees. I think possibly, as you said, maybe moving into subspecialisation early on is probably not the way to go. And I suppose, again, with this new curriculum, we're focusing less on kind of time and more on individual trainee progression and outcomes, which is very important as well, because some people may have more exposure than others to certain things or certain conditions, or it depends on your training route, I suppose. So again, I think the new curriculum will be positive in that respect as well. But in answer to your question, I think it's very important to have a good foundation in terms of general skills and emergency skills.
And Stephen, if I could ask you, as an ST2 trainee, and I know you haven't maybe entered phase 3 or phase 2, sorry, you haven't started in your higher surgical training program just yet, but what's your initial reaction to some of these changes that have been brought in by the new curriculum?
I think, like, overall it's a good path. I mean, I think it's important to be able to, going back to the point of a day one consultant, and you do need to be able to take the undifferentiated call. I mean, if you are working in a centre, you are going to be on call, and I mean, I think having an emphasis in the phase 2 of having more exposure to general surgery, which is what I'll be applying for, I think it is a good thing. There is obviously an issue with just getting exposure into cases as well. So, trying to make sure that you get a good case mix over, the 4-year period, and making sure you're competent to perform those procedures is the goal. And I think having that 4-year period does give you that window.
And then another aspect of the new curriculum is and again, Amy alluded to there, is this whole area of competency-based medical education. And when it comes to skills acquisition, Haroon is towards the end of his surgical training, but under the terms of the new curriculum, there's maybe less emphasis on the number of procedures that you perform and more of an emphasis around competency. Now that involves the need for significant consultant input into the assessment of your skills acquisition. So Haroon, you're nodding your head in agreement with me, but maybe I'll ask you, what are your thoughts on the concept of the multiple consultant report, in terms of the concept of having multiple consultants looking over your performance, so to speak, and making an assessment about you in terms of all of the capabilities in practice and including your operative ability?
I because I'm towards the end of my training, I had the opportunity to stay on the old ARCP pathway or this one, but just looking at it, I think it's welcome. I think it should be very welcome. I would see it as a huge positive. You get to interact with all your consultants. You don't have just one consultant trainer. And then, like I said earlier, that proficiency-based progression, that's going to come into it from what I can see, and especially in robotic surgery. So why not instill it to our juniors from a younger age and younger stage in their training? I think the big thing, again, just picking up from the last year, is it's not putting you down. It's just you are progressing in this way, but this is how you can be better, and having those open conversations with your trainee in a non conflicting manner. That's the way it's supposed to be, and trainees should not be taking it harshly either. Like he said this to me, we want you to get better. That should be the aim, and trainees should take on any criticism that they receive with open arms and just learn from it. I think that's what I've learned as well.
Certainly from my conversations with trainees across different specialties, there generally seems to be a very positive reception amongst trainees to the core elements, shall we say, of the new curriculum. And it also includes the possibility of maybe, if you like, progressing through the training program maybe a little bit faster, maybe in selected circumstances. In individual circumstances where a trainee is performing to a very high level of competence, and where there's, if you like, agreement amongst the multiple consultants, so to speak, that this trainee can progress maybe to a higher stage or a higher level within the training program. Amy, what would be your thoughts on that? In other words, you mentioned to me earlier on, you were talking about flexibility within training programs. Do you think it's a good idea that the training program incorporates that element of maybe allowing trainees to progress through a program a little bit faster in selected circumstances?
I think so. I mean, I suppose we have obviously reduced the length of the surgical training scheme. And I know before this, Ireland had one of the longest surgical training programs, and obviously that produced some of the, most internationally renowned surgeons, and we know that our surgical training program is very renowned worldwide. But I think we need to take the shift off kind of time and, as you say, look at trainees more individually. Some people will learn things faster than others. Some people will have different exposure. And I don't necessarily think that time or numbers should be focused on. I mean, I think there does have to be a certain, there is always a certain minimum amount that it will take to train somebody. There is a certain volume that's required. However, we do have a much more decreased number of cases, surgical cases or surgical lists. The volume of surgery is decreased. And so we need to be a bit more clever about maximizing training opportunities and about kind of taking the most from training that we can. So I think the idea that people will be able to kind of focus more on their competencies rather than on specific numbers or specific amount of time that they've been in training is very important.
And how can we then, maybe I might ask Nicola, how can we then as consultant trainers, how can we assist in this process of, if you like, improving your training experience during times where maybe there are less elective cases being admitted for surgery? And I guess where I'm moving here with this is the concept of professionalized learning and, dedicating time on a list to allow if you like, a greater level of training experience for, say, something like an inguinal hernia or a laparoscopic cholecystectomy, just as examples. How can we, as a consultant body, how can we help you in that regard?
Well, I suppose from the RCSI, like, the provision of training days is extremely important, especially, as we're all saying, we're having less time in training. The European Working Time Directive is trying to cut it down even further. So I think, efficient training is the key here. And I think RCSI can do it by giving us good training days. And then in our individual hospitals, then in the ethos of the multiple consultant reporting, just really good, high quality, personalized feedback. I think that's really the way forward. Just honest feedback, based on exactly what you've seen the trainee perform, and based on what you've learned from the college. I think that's probably the best way. Just individualize it as best as we can.
And out of interest, have any of you participating with us tonight, have any of you been assessed so far by the multiple consultant report?
No.
No, not maybe yet. I know that in the trauma and orthopedic specialty, that they've had some of their midterm ARCPs, and coming up during the Millen meeting next Friday, February 4th, Owen Sheehan is going to talk about the MCR and the issues that it has raised for the consultant trainers. But as a concept, are you all happy or comfortable with the idea of the multiple consultant report and what it's there to achieve? Haroon,
Yeah,
again,
I think
you wouldn't have necessarily been exposed to the multiple consultant report as you're on the old curriculum, but maybe that question is maybe directed more towards maybe Amy and Nicola and Stephen.
Prof, I think it can only be a good thing. The more feedback we get as we go through training can only be a good thing. And even if it's pointing out what we're doing wrong, as Haroon was saying earlier on, it's not to chastise, it's to encourage us to get better. So I think multiple consultant feedback can only be a good thing.
Stephen, what would you say? You're on mute, Stephen. Sorry, Stephen, you're on mute.
Oh, sorry. Sorry. I think it is. I mean, it will be a very good thing. But I do think there will be definitely a teething period for the next, months to years until this is the way that it is done now. Because I think even just from from a setup and a timing for consultants to give this sort of feedback will, getting a set time to do anything in a hospital is difficult enough without adding another meeting now on top of that has to be performed every couple of months. It will be a challenge, but I think it is definitely
and it's certainly very good to hear Nicola and Stephen at this stage in your careers highlighting the importance of the process of feedback. I think that's critical here, is that feedback, constructive feedback, is provided by consultant trainers to trainees. And I guess we're at a stage in surgical training where we're coming out of the COVID pandemic, and hopefully things will start to improve reasonably quickly from this point on. But I'll ask all of you, from your perspective as a trainee, are there further things that we can do at this point to improve your surgical training experience as we come out of the COVID-19 pandemic? Maybe if I start with Haroon.
I think the RCSI should be commended on the great training it does provide, especially going to the UK and them appreciating the skills that I've learned both clinically and surgically, and the history that they have of making good Irish trainees, making good surgeons. So that's something we need to commend. The RCSI and what they do is good. I think going forward, how we can improve it is we have these simulation labs. We just need to improve them and make them wet labs, and then bringing all the other, like you said, the robotics in the future and other technologies which are all coming, and we are working on it. We just need to improve on it, and I think we have the staff. There is dedicated people in the college who do all them, and they're all involved in all the different specialities. I know a few of them in there. You know, they have different models for different specialties. We have basic skull and neurosurgery, or hips and joints, and like and for urology, you have multiple different cadavers and everything available. And more recently, from a transplant point of view, we held a retrieval workshop where we did organ retrieval, multi-visceral organ retrieval on porcine models. So I think the RCSI is there. It's really good. We're just, you know, the trainees need to bring it forward, as well as the trainers, even, and make it even better. Like, but overall, I think we're all very lucky to be in the RCSI, and we actually do get trained very well.
And then, you know, given Amy the current environment, from your perspective, are there any suggestions that you might have as to how we might improve the delivery of surgical training, or make it better than what it is already?
Yeah, I think two things, and Haroon has alluded to this already. I think simulation is not a replacement for real life operating, but it can definitely help to maximise training opportunities and to maximise intraoperative learning. I think the one thing that the COVID pandemic did highlight was that obviously if you didn't live close to Dublin, you know, maybe you didn't have access to surgical simulation facilities. And I think maybe the idea of some kind of regional training hubs and protected time for trainees and trainers. I mean, I know as much pressure as we're under as trainees, consultants are under more pressure, and the COVID pandemic has, of course, caused a huge administrative burden, a massive backlog of cases, and it's very hard to ask a trainer to find time to sit down and go through you know, specific parts of an operation you might have found difficult. But I think it's very important to try and maybe take some of those learning opportunities outside of theatre, where we are under time constraints, and where maybe we can't use a whole case as a training opportunity, and try and do some of that outside of the operating theatre. I think that will be crucial. And I think the second thing, which I mentioned earlier, is ensuring flexibility for trainees. As I said, this has been an incredibly stressful time for everybody, and taking trainees out of their support structures will only further add to that. So I think listening to the needs of individual trainees and ensuring that they have as much flexibility in training as possible will be very important as well.
Okay, well, thank you very much. Now, I'm going to allow some questions at this point from our audience, from our webinar audience. But before I do that, I'd just like to thank you all most sincerely for participating in the webinar this evening. I always find it fascinating to listen to the trainees, and I'm delighted that we had the opportunity this evening to put you centre stage, so to speak, and you'll be centre stage again at the Millen meeting as well, because much of the Millen meeting is focused on issues around training from both a trainer and a trainee perspective. And I'm looking forward to hearing all of that. So one of the questions then that our president, Professor Ronan O'Connell, has asked is your views on the utilisation of the private sector to, if you like, provide you with more exposure to elective surgery. Maybe if I could maybe start that with maybe Stephen, maybe what would be your thoughts on that?
I mean, I think it certainly would be I think it certainly would be an option. There is, you know, like there's a large caseload that does go on in private hospitals. I mean, I think if and a lot of consultants would share, you know, they may have joint positions in, you know, in a private hospital as well. So, you know, bringing their trainees over to perform these operations, you know, I think would only be a positive. I know in the UK that is a thing that there's a push for that to happen, or if it's not already happening. So I think, you know, on the overall, I mean, it would potentially be an option, but that would need to then go through the private hospitals and have them on board to you know, to be happy with trainees coming over.
During the COVID-19 pandemic, I guess we did have some elements of that with regards to provision of surgery for cancer cases. And indeed, there were circumstances where trainees and trainers travelled together to private hospitals to perform these operations. And certainly that appeared at the time to work very well. So Perhaps maybe, Amy, from your point of view, would you see a role for the private sector in, helping to maintain good exposure to elective surgery, in particular for surgical trainees?
Absolutely. I think once it's uniform across the board and there's an agreement in place and all trainees have the same access, then I think definitely, I think we've seen the private sector can be very efficient in terms of turnover of cases, and that can kind of maximize the amount of time for intraoperative training. So I think it's definitely welcomed once, as I say, all trainees have the same access, which I think was maybe a slight issue. Not every specialty or not every region had the same access to cases.
Nicola, would you have thoughts on the use of the private sector for elective surgery for trainees?
Yeah, definitely. I mean, I experienced it last year. It certainly opened up a door into the private sector that we kind of never really considered before. And I got, to attend many elective lists there. And I thought it was a fantastic experience. I completely take Amy's point that maybe not everyone was so lucky in access. And from a regional point of view, it's probably going to be an issue, but I think if we can implement it in a fair way, I think it would be a fantastic opportunity for trainees to get into both sectors. Yeah.
As we're coming towards the end of our hour this evening, I must say I could keep talking and interacting with you for another hour or two, but that's not allowed under the rules of our webinar series. But maybe my final question to each of you would be, what would you say to a fourth-year medical student who is potentially considering a career in surgery? Maybe starting with Haroon.
Exciting times ahead, especially in urology and transplantation, robotic surgery, xenotransplants. It's in the news these days, so fields are incredible. And then if you're a medical student, I would say get involved, find that senior registrar, figure out what he's up to, go follow him, go to his clinic, go to his theatres, and only then will you figure out if you like it or not. And if you do like it, then get involved. Dive in.
Stephen, what advice would you give a fourth-year medical student who's interested in career?
Something similar. I mean, surgeries is an excellent career. It's a complete, it's a complete career where you're working at a craft for 40 years. It is something that, that you work at and you can see steady incremental improvements, and you can offer a service to patients where, you can really change their lives. For getting involved in it, I suppose, having gone through the new application system, I think it would be just important to, if you do think you have an interest in surgeries, asking, can you attend clinics, go to theatre, go to ward rounds, and see what working as a surgeon is like. The one caveat I would have for that is just, if not to be too spoiled when you are an intern, and that's, I think, working as an intern is not a very fair representation of what it is to be actually working as like a surgical SHO or registrar, and there's a big discrepancy in that.
Amy, what would you say to a fourth-year medical student who's considering a career in surgery?
I'd say be ready for the challenges that surgery presents. As Stephen said, it's a very rewarding career, but it does present certain challenges that are different to other specialties. So definitely make sure to get plenty of exposure and know what you're in for, and get involved with surgical societies, and get involved with organisations like ISTG and ASIT, and get your portfolio kind of up and running early on. And the last thing I would say is find a mentor early. I'm very lucky that I've had multiple mentors throughout my career. You've been one of them, Prof. Barry, who've guided me through my surgical career. And I think it's very important to make sure that you identify role models and mentors early, and have good supports around you early on in your career.
And I'll give the last word to you, Nicola. From your point of view, what advice would you give a fourth-year medical student interested in?
I definitely encourage it all the way, and I would advise them to get into as many different theatres as possible early on, because we do have to pick quite early in training, so just to get as much exposure as possible. I'd encourage them all the way. I think it's, you know, one of the most structured training programs we have here. There's a relatively, you know, small class feel to our years. There's about 60 in my year and Stephen's year, so we all kind of get to know each other. Which is quite unique in training bodies, I think. And also, as Amy said, I think the mentorship is unparalleled in surgery. I think, you know, from colleagues and, you know, ST7s, 8s down to us and the likes of yourself, Prof. I think it's such a key component to surgery, and I think it's a very attractive feature of the specialty.
Thank you very much. On behalf of RCSI, I would like to thank all four of you most sincerely, and I'm heartened to hear all of your positive comments this evening. So I'm going to hand back to our President, Professor Ronan O'Connell, to finish our webinar this evening. Thank you very much.
Well, thank you, Professor Barry, and congratulations to all of you. Thank you for really a vibrant discussion. I think we're all enthused by your enthusiasm. We're reassured by your reassurance regarding the training. It's nice to know that when you go abroad, as you have, Usman, you feel that you have come from a training program that has stood you in good stead. And I'm just reflecting, if I was a fourth-year medical student, what would I do? Our advice, I'd say immerse yourself. And that's actually what happened to me many, many years ago when I spent a summer in Ardkeen, when there was just one county surgeon, Jack O'Reilly. There was no subspecialization, and we did everything. Now, I just feared that that wouldn't be the case, but it was a wonderful experience as a student to immerse yourself in surgery. I think, or I have thought for a long time, that people like Kevin Barry and myself have seen the golden age of surgery, but I suspect there's a new golden age ahead, and I wish you all well, and thank you for your enthusiasm, and thank you all who have joined in. We've had over 100 people on the webinar tonight, which augurs very well. So thank you all. And I want to especially thank in the background, Catherine Jordan, Padraig Kelly, and our Vice President, Laura Vianney, who have helped organise the webinar series. So good night and thank you all.